So see the growth of the Philippine medical schools. So started with 7, and now in 2017, we have 50 medical schools scattered all over the country. So I'd just like to show you the distribution. Siguro you might be interested, okay? So kung ano yung color nun, doon yun. So this is the NCR, okay? So yun ang part, yung pink, yun ang NCR, okay? So there are 17 actually, 17 medical schools in NCR. Actually, ang number 18, I think, is Chinese General Hospital and Medical Center School of Medicine, which I think has started already this year. Okay, so 18 na po yan. So ang hindi, medyo siguro hindi nyo alam is the AMA, we have the Manila Theological College. This is actually from Korea. It's a Christian college. Okay, New Era, which is the Iglesia ni Cristo. Okay, and then we have San Beda College. Ateneo is also a School of Medicine now. And of course, number 18, sabi ko nga, is the Chinese General Hospital Medical Center. Okay, so 18 na po yan. Now in Region 1, so yun po yung Region 1. Alam ko medyo nakalimutan nyo na yung mga regions. Okay, so dyan po yan, yung parehong kulay. Okay, so Region 1, we have 4. Okay, so Lyceum, Mariano Marcos, University of Northern Philippines, and Region 9 is 1. This is the Ateneo de Zamboanga, University School of Medicine. And then Region 10 is tatlo po. There are two schools, the Davao Medical School and the Brokenshire. So this is actually now the distribution. Now let me share with you some historical milestones as far as the
in classes. Thank you so much, Grace. It has been 25 years, but we still look the same from 25 years ago. So it's most of my classmates of 1993. So anyway, this is first slide, and how to attenuate chronic inflammation and insulin resistance in lifestyle diseases such as diabetes, obesity, heart disease, and cancer. But the good news is today I'm not going to talk about insulin resistance. I'm not going to bore you about the epidemic, and no one is exempted to this kind of epidemic. So as the weight rises, diabetes rises. So when we talk about diabetes, we really talk about cardiovascular disease. It's unavoidable. And actually, after 30 years, which is that we call the legacy effect, your heart has been shown to have some benefit with intensive glucose control. When we look at the CORD study, where the intensive treatment group had to have an A1C of less than 6%, there's a definite reduction in microvascular complication, but there was no benefit on your cardiovascular complication or reduction in your cardiovascular complication, and there was an increase in the mortality, all-cause mortality. So this gave us so much concern if we're doing the right thing of reaching an A1C of less than 6%. So there comes advanced study. Again, an intensive treatment group of an A1C of less than 6.5% or less. There is no benefit both on your cardiovascular complication and mortality reduction. The VA study has shown a reduction in your cardiovascular complication, the choline, and the gut flora eventually makes TMAO. Okay. Few more things. Okay, so I'm not making it up. This is what it is. Okay, this is a classification, Group 1 classification. And red meat is actually Group 2A when we talk about sources. Where is my protein? Of course, you're going to have your protein from plant. And the WHO only requires us 10% of your daily total caloric intake to protein. Intake is 10%. Above different kinds of diet, non-vegetarian, semi-vegetarian, you really could achieve, 0.8 grams per kilogram per day. So don't worry about getting enough protein. You don't need a lot of protein. So if you're so these are if you're really interested to do this, there are 7 cardinal rules. Whole food, So what is whole food? Whole unrefined or minimum refined plants. 8%. You have to have 6%. I know, time's up. If you don't want to do anything, and just think about saving the world. Okay? Less young kids being enlisted in the army because they're heavier, they have more cardiovascular disease. So this is going to be a problem.
So he's now of the Department of Preventive and Family Medicine. He's currently the chair and head of the OPD, UST. He's also connected with the Philippine Sports Commission. So he will talk more on the lifestyle management of the metabolic diseases.
Which we actually single digit in the 1980s to 16.6 in 1993. It's now up to 31 relative to 13 data. And where do we see them? Of course, this is my age group. Yours, 10 years younger, of course, as your batch 93. But where do you see them? Still, from middle to the degree in 2013. 31.4 to 46.9, and to see that they are not in touch. 1 plus 1 plus 1, of course, rises to times 16 times relative to cardiovascular outcomes. And this is as today, 2009 and 2010. High impact, we go shorter. We need to understand progression. So it should be a combination of aerobic, so anywhere from weight bearing seniors doing their work, of course, warm up, stretch, cool down, and in summary, what we like you to do is the exercise routine. There's no time in the gym, then we can increase indulgence relative to activities of daily living. If,
He has 3 children,
it need be
ages
that
17, 21, and 25. His current blood pressure is 135/70, and his cholesterol, triglyceride, are all NLDL, bad cholesterol.
Good morning. I'm Dr. Ronald Santos. Actually, we are facing here a patient, a very with type A personality, 50-year-old. I don't know if it's female or male. Okay, male. Okay. Okay. So with different risk factors like hypertension and also
metabolic syndrome, if you will consider the criteria, 3 out of 5, no? So definitely this patient, and also I will be starting him already on anti-hypertensive medication, and also the
gases and Dr. I mean, truly the metabolic syndrome, there's all the mere fact that you have these risk factors, you have the tendency
the causes of hypertension is multifactorial.
So, well, we all know the different causes like vasoconstriction, vascular remodeling.
Good morning. Thank you, Grace. So we are presented with a middle-aged man who has metabolic syndrome. I'd like to point out the diagnostic criteria. He has a BMI of 28, waist-to-hip ratio is 1.2. He has a fasting blood sugar that is consistent actually with type 2 diabetes already. Previous year it was 7. I'm not used anymore to the S System International, so I have to calculate it in. From 7, which is about 126 in milligrams per deciliter, and we know that the cutoff for diabetes is 125. In a matter of a year, it went up to 7.6, which is 136 milligrams per deciliter. And based on this, he has not been treated as far as metabolic syndrome is concerned. It is very important to note that when you're diagnosed with type 2 diabetes, you already have, upon diagnosis, you already have a 50% loss of your pancreatic function. So it's very important to diagnose them early. How do we do that? Screening test has been focused on fasting blood sugar, but it's even more important to know the response of the patient as they are challenged. So I always ask patients to, if you have family history of diabetes, after Thanksgiving or after Christmas or after New Year's celebration, check your blood sugars 2 hours later, and you'll be able to screen a lot more, and you'll be able to get them a lot earlier, which I think is the key to treatment of diabetes metabolic syndrome. In this case, he needs to be on treatment. In addition to lifestyle modification, as Dr. Cassis has pointed out earlier, metformin is most likely the best choice for him. I don't know his kidney function. We don't have any other information, but metformin is the first line of agent for type 2 diabetes. Historically, glycemic control has been very glucose-centric, which means that the focus was always on hemoglobin A1C, post and pre-prandial blood sugar control. But recently, we realized that cardiovascular events, in fact, diabetes is a heart disease risk equivalent. So we have to address that issue. And fortunately, recently, there are large studies utilizing certain diabetes medications, particularly the SGLT2 inhibitors. I would say maybe it's a class effect, that there is also a cardiovascular benefit, both in the patients with atherosclerotic heart disease and patients with CHF. So these are the SGLT2 inhibitors. But with him, I would start with metformin, lifestyle modification, and then 3 to 6 months later, I'll check his hemoglobin A1C. And if there's no improvement, it is expected to improve about 0.7 to 1%. If there's no improvement, I will add either SGLT2 or DPP4 inhibitors. The BMI is 28 and he's overweight, not really morbidly obese, so the DPP4 and the GLP-1 agonist may not be the best option for him. Certainly, insulin may not be indicated at this point. We don't know any other information except for the fasting blood sugar. Do you want me to comment on the cholesterol too? Okay.
Next question.
Okay, sorry. Again, I'm not. So most patients with diabetes, their lipid profile is really more of high triglycerides and low
You can call me
HDL.
Bong. Well, let me just first mention to you that the average, this is a current data from the Wallet Hub, and it was published in the CHEST Bulletin in January 2016, but this is a US data. And let me just tell you that the average smoker spends around $1.6 million or $31,000 annually over a lifetime, 1.6 million. And there are 66 million US tobacco smokers. And really the impact is they spend around 320 billion a year spent on cigarette and healthcare. And 170 billion is on direct healthcare costs and 156 billion is on productivity. Now let me go back to the association with the metabolic syndrome. We all know when we were students that really it's a strong risk factor for atherosclerosis, and it has a dose-dependent relationship, meaning if you smoke more and you have a high risk, then you develop more of the disease. Smokers have abnormalities in lipoprotein metabolism. Jay mentioned earlier about the lecithin, and it can decrease it, and also or lower your HDL cholesterol. And you have higher abdominal obesity in some patients. And there's the association with are more likely to stop smoking, and it could have helped him. So there's a dramatic increase in the use of e-cigarettes from 2010 to 2014. Now, was this associated with decrease or cessation in smoking? Well, for some patients it has helped, but we're talking about other
Anyway,
patients.
this is what I can comment about
they
this
look like
case.
this and like that.
Of course, before they became like that. Okay, I think a lot of factors have already set in. Okay, so if you're saying that the kid is already 17 years old, okay, maybe a little bit too late for intervention, but we try our best. So the pediatricians, don't forget to be, okay, in our local setting, it is recommended to screen for BP from age 3 years and onwards. So initially we use the 4-limb blood pressure, but well, just to rule out all.
Thank you. I have a couple of questions. The first thing is this patient that's being presented anesthesiologist and practicing general practice now in one of the remote areas in Aurora, and probably almost 85 to 90% of them are on the poverty line. I see a patient like this. I whether if I am this patient, how will I check and how will I know what's going on with my blood pressure? Is it going up? Is it going down? So with
When you
me,
see a patient having hypertension, it's really important to tell also the associated cardiovascular risk factors, especially like this patient is
Of batch 93. Good afternoon to each and everyone. I'm very, very much humbled that I am chosen to be a speaker in this prestigious event, and I'd like to thank the organizers or all my batchmates. Hindi ako makahindi. Okay, so now I'm going to talk to you about the raging the war against
For this discussion, I'm going to use that terminology based on the definition by Dr. Martin Blair of WHO and our own Department of Health. So, when we talk about antimicrobial resistance, it is we have to keep. If I have my colleagues here, the infectious disease, that is our last. So, in order also to look at how it will impact, I just wanted to show you that several experts are saying that we might actually go back to pre-antibiotic era, and the cause of have any local data for this, so that I cannot discuss it at present. So in fact, this is about.
Batchmates, it's great to see all of you after 25 years. So I am tasked to give this talk about targeted therapy in inflammatory arthritis, and I'm going to try to summarize this in 15 minutes. And this can create a lot of joint damage and disability if we don't treat these patients properly and at the right time. But also the problem is that these are systemic conditions, and so that there are a lot. It's a dysregulated immune system, and so even if they categorize your immune system into the adaptive and innate immune system, they actually are not mutually exclusive. They are actually cross-talking within each other. And so the general concept is that if you have an autoimmune condition, is that you have a genetically predisposed individual and possibly an environmental trigger like a virus that now turns on the genes to express itself. And once you have that turn on mechanism, it's commonly seen among middle-aged females, and you can see that commonly it presents as a symmetric inflammatory condition, and they have a lot of systemic conditions or symptoms such as fever, low-grade fever, malaise, or fatigue. But when you get to see or diagnose an RA patient very early on, what you may just see is actually inflammatory conditions where you have synovitis of the joints. But if you can catch this arthritis very early, you can see that they do not have any X-ray damage yet. For the longest time, I think that many of our patients did not understand about rheumatoid. They all think that it's from food intake. They just self-medicate with pain relievers, so they sometimes come to us years after presentation with already chronic changes. And we don't want to see these patients at this stage because whatever has been damaged cannot be reversed. Another set of inflammatory conditions are what we call the spondyloarthropathy. So this is a very large or umbrella term for a common family of conditions. And we know that the prototype spondyloarthropathy is ankylosing spondylitis. But we also do have other rheumatic conditions within the same family, such as reactive arthritis that we commonly see after sexually transmitted diseases, or also psoriatic arthritis, that common skin condition where 25% of patients can also have concomitant arthritis. But this is the general feature on how we can differentiate ankylosing from other types of spondylosis or psoriatic. And I think that we know that in ankylosing and in reactive arthritis, it's more commonly seen among males than females. But in terms of the spinal distribution, we get to see it more in ankylosing spondylitis. And I just wanted to show you that dactylitis or sausage-shaped digits, which I will show you later, is a more common feature among patients with psoriatic arthritis. HLA-B27 is a common genetic marker, and we know that it's more commonly seen or associated with ankylosing spondylitis, but less commonly seen among patients with psoriatic arthritis. So this is ankylosing spondylitis. This is the same patient, and chronologically, from the 1940s until the 1970s, you can see the progressive nature of this arthritis with a lot of disability. And for the longest time, we could not really offer much for these patients except pain relievers and probably to tell them to do some low-impact aerobic exercises such as swimming. But this particular spondyloarthritis family, you could see that spinal involvement is very common, and I hope that you can appreciate that the right sacroiliac joint is already fused and sclerosed. And for ankylosing patients, the first joint affected is the sacroiliac joint. Then it migrates upwards towards the spine. I hope you can appreciate that in patients with spondylo, you can also have asymmetric arthritis. And if you could take a look at the right third proximal interphalangeal joint, there is marked swelling or synovitis in this particular joint. And this is the worst. This is what we call arthritis mutilans. This is the most aggressive form of arthritis, where you can see that there is bone dissolution, and you could have actually what you can say telescoping sign. Because the bone is already destroyed, you can move the overlying skin to and fro like a telescope. And so this is again the reason why we need to diagnose and manage these patients properly. So if you look at it, patients with spondylo can have beyond arthritis, other involvement of structures around the joint. Some patients can have dactylitis, or what we call sausage-shaped digits, very much looking like a cocktail hot dog. And sometimes you can also have enthesitis or enthesopathy. And if you look at the right-hand side, you will see that this is a patient with a very, very swollen right Achilles tendon. And so I just wanted to share with you, because for the longest time, we rely our management on our assessments, based on history and physical exam. But now we also do ultrasound for the joints, and we can see real-time actually the examination of a particular joint. And patients do appreciate the fact that they can see this without any ionizing radiation. We can demonstrate enthesitis or enthesopathy, and you could see those hot red signals signify inflammation, and this is inflammation in the enthesis or at the attachment of the tendon into the bone. And so there are a lot of other applications. We can see inflammation in psoriatic skin lesions as well as in the nails. So it's a very nice way by which we can monitor patients on how they respond to treatment. So how do we manage patients with inflammatory arthritis? We just need to remember two things. We want to diagnose patients and treat them early. And we have a target, which is achieving remission. And remission means no tender and swollen joints, normal inflammatory markers, no joint damage, because we want to preserve function. We consider inflammatory arthritis as a rheumatologic emergency because time is of the essence, and because whatever is lost and whatever has been damaged cannot be reversed. And in RA patients, we can have irreversible joint damage within the first 2 years. And so treatment. For the longest time, this is our problem because steroids can be bought over the counter, and some people even think that steroids are vitamins because they see their children growing and getting fat and they're eating very well. But we know that steroids have a lot of side effects, and I don't have to go through all the entire list, but we don't like steroids. And so when we talk about DMARD therapy, which are these oral non-steroidal medications that can prevent joint damage, these include drugs like methotrexate. The problem is that up to maybe a third of these patients do not really respond to conventional treatment. And so we need to have better therapies, and we now have biologic agents, which are therapeutic agents that really target specific pathways of inflammation.
Cannot be. Number one. So, dealing with the dysfunctional physician. Okay. Okay. So, first quotation. This is lifted from the Mindful Self-Compassion Program. There are no difficult people, only suffering one. So, if you want not to be labeled as, it is clear that the disruptive colleagues is an enduring concern in clinical and training settings, and there are
Patients, nurses, healthcare executives, and other healthcare workers revealed that 77 witnessed disruptive behavior, and 67 of the respondents agreed that disruptive behaviors were linked to adverse events. Don't blame me for that. That is based on the book.
Okay, walang psychiatrist kasi pumupunta sa atin eh. Okay. So, what are examples of disruptive behavior cited by the American College of Obstetric and Gynecology? One is using profane or disrespectful language, yelling, berating, or insulting co-workers, throwing instruments, charts, or other objects, bullying, demeaning, intimidating dialogue, criticizing, making overt suggestive sexual comments, using sarcasm, non-verbal gestures, or passive-aggressive behavior. When you say passive-aggressive behavior, these are hostile avoidance or the cold shoulder. Di ka mamamansin. Okay? Intentional miscommunication. Pinagtataguan ka. Di ba, Ida? Unresponsiveness to professional requests. Speaking in inaudible volume, condescending language, impatience, participating in malicious gossips, no, mga chika baby, joking about race, gender, sexual orientation, or religion, commenting on personal appearance, okay, and implied threats or retribution for filing a complaint. No, siguro meron nangyayari dyan sa atin. So, disruptive physician exhibit a broad range of behavior that have multiple causes, okay? You can either have professionalism problems, which can compromise care, and a psychiatric status problem, okay? You may have personality traits, personality disorder, you may be bipolar, you can have drug or alcohol, and even dementia, okay? So pag nakakalimot na, tama ng pagpapractice. Alright, so how do we do? How do we assess? Okay, if you have a disruptive physician within your within your group or within your hospital, so seek for psychiatric evaluation. Okay, and then if psychiatric, it could either be you have psychiatric issues present or psychiatric issues absent. So what to do? If you have psychiatric issues present, if it is enduring, significant, you can have significant